Thank you all for joining us for today's webinar on the diagnosis and pharmacological treatment of overactive bladder. My name is Jessica Monmany, and I am the Senior Education Associate at ARHP. I will be moderating today's webinar. Before we begin, I would like to share how you can receive continuing education credit for this webinar. In order to receive credit, you must take the pre- and post-test. If you have not yet taken the pre-test, please click the link in the webinar's chat box. You can also use this box to enter questions throughout the webinar, which our presenter will answer at the end. About an hour after the conclusion of the webinar, you will receive an email from ARHP's education team with a link to the post-test survey. Your continuing education certificate will be generated upon completion of that survey. In 4 weeks, you will receive another email with a link to the follow-up evaluation. We ask that you complete this evaluation to let us know how you've incorporated what you learned during this webinar into your work. Completing the pre- and post-test, as well as this follow-up evaluation, helps ARHP ensure we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. Before we begin, we would like to acknowledge that the content of this presentation is made possible through an independent educational grant. And at this time, I would like to introduce our presenter for today. Dr. Krause is a professor and vice chairman of the Department of Urology at the University of Texas Health Science Center at San Antonio, where he heads the section of female urology, neurourology, and voiding dysfunction. In addition, Dr. Krause heads the Neurourology and Urodynamics unit at the Spinal Cord Injury Center at the Audie Murphy VA Hospital and serves as medical director of the South Texas Pelvic Floor and Bladder Center. Dr. Krause is widely recognized for his roles in education, which include Program Director for the 2-year Fellowship in Female Urology, Neurourology, and Voiding Dysfunction at UT Health Science Center, service on the American Urological Association Urology Core Curriculum Section for Neuropathic Bladder, and participation in education committees for both the Society of Urodynamics and Female Urology and the Texas Urological Society. We're thrilled to have him with us today, and I will now hand it over to Dr. Krause.
Thank you, everybody. Appreciate you all taking the time for being here in the middle of the day. Maybe it'll be a break. So let's get moving. This is a significant work in progress. It may not seem it when you look at it from your perspective, but there's a lot of people involved. You can see there that's everybody that was involved, the disclosures and such. So today what we'll be doing is we'll talk about overactive bladder and identify the symptoms of overactive bladder, the workup for it, when to treat, when to refer to a specialist, talk a lot about overactive bladder and how it impacts on the quality of life of people, what you need to consider when working up overactive bladder in terms of differential diagnoses and other things to worry about, review the treatment options, pharmacologic treatments that you see there, but there's more than that. There's the first-line therapies, which we'll spend a little bit of time on as well as when to refer to a specialist for, say, third-line therapies if you don't do them. And go over why it's important to treat, because some people consider this disease to be, or this syndrome to be not a serious problem, but hopefully at the end of this webinar we'll at least understand how it can severely impact people's quality of lives. And I'm hoping everyone can hear me okay. You'll let me know, right? Okay.
Correct.
So what? Great. So what is overactive bladder? It's actually a syndrome or constellation of symptoms. Urinary frequency, urgency, nocturia, urgent incontinence as well. Urgency is the hallmark symptom. It's the symptom of urgency is a compelling desire to void that's so strong and intense that you fear that you have to stop what you're doing and run to the bathroom, perhaps for fear of having an accident, or you actually might have that accident on the way to the bathroom. Frequency, typically we consider anything more than 7 voids per day. That's usually based on population-based studies in terms of what's considered normal and not. Nocturia, by definition, is waking up at least once a night. So if you wake up more than that, or one or more times, you have nocturia. But the key thing here is the degree of bother. So if you have a patient who's waking up twice a night and it doesn't bother them, then they don't need to be treated. If they have someone going to the bathroom 10 times a day and it doesn't bother them, they don't need to be treated. On the other hand, when you have patients who are going so frequently that it prohibits them from engaging in social activities, going out, because they're fearful they're going to be in a place where there's no easy access to a bathroom, that's where the quality of life impact comes in, and that's where the frequency may be just too much for them. So, and of course, urgent continence is also always wrong. If you leakage when you can't get to the bathroom, that's not the way it's supposed to happen. Now, it may not bother the patient, in which case we'll, maybe not treat them, but maybe we can still offer them assistance in terms of living with their incontinence so it doesn't impact them as badly as it is. So what you're looking at now is a fairly simplified cartoon or diagram of the Micturition Cycle. I've always said all the years of my training, you can summarize it basically into 2 sentences. The bladder fills with urine and it empties with urine. That's what I learned in all my years of residency and fellowships. To make it a little more complicated, so I have a reason to be, basically as the bladder fills with urine, the bladder muscle should relax and accommodate more or higher and higher volumes of urine and keep the pressure inside the bladder low. This, in addition, the outlet of the bladder or the sphincter should stay closed, and all that should prevent or minimize any leakage, and it should allow the bladder to continue to fill. And again, keeping those pressures low. As the bladder starts filling, you'll get appropriate sensations. Bladder's a little full, it's a lot full. Maybe it's time to find a bathroom. But again, it shouldn't be so strong or so pathologic that you have to stop what you're doing and run to the bathroom. You should be able to hold it until it's socially acceptable and appropriate. When it comes time to void, the first thing that actually happens, a fairly coordinated event, the first thing that actually happens is your sphincter will relax, and then your bladder will then contract, and as it's contracting, you'll get the bladder emptying. So that's the normal process. Where it goes wrong is if you have what we call involuntary bladder contractions, where the bladder contracts before it's supposed to. And I'm going to ask a technical question. Can y'all see my mouse when I'm doing this? Can I use that as a pointer?
Yeah. Yes, we can.
Okay. So this is where the bladder is contracting, and this was a voluntary contraction because the person wanted to void. However, over here in the middle of holding, if the bladder were to have a contraction, that's one of the reasons, or one of the theories about why you may get overactive bladder. So a lot of people confuse or get a little confused between what's overactive bladder and the different types of urinary incontinence that may or may not be associated with it. So overactive bladder is, again, frequency, urgency, nocturia, and urgent incontinence. So when a patient has urgent incontinence, they have overactive bladder. Where it gets a little confusing is that patients have other types of incontinence as well. You may have what we call stress incontinence, which is where you have leakage associated with activities such as coughing, sneezing, exercising, and such. Basically, the problem there isn't the bladder causing a spasm. Instead, the sphincter or the outlet isn't closing tight enough. When you put pressure on your bladder from the outside, such as by a cough, it forces the opening of the bladder to open, and then the urine gets expulsed out. So that's stress incontinence, which is not part of overactive bladder. We talked about urgent incontinence, and then there's mixed incontinence, which in my practice actually is probably more significant than the stress, and I think that's just a factor of geographic and also my referral patterns. But as patients get older, the urgent incontinence and the mixed incontinence do tend to get worse. Mixed incontinence means they have a combination of 2 types of leakage. Most commonly, it's going to be urgent incontinence and stress incontinence. And that's important to differentiate when one has one versus the other or mixed, because if you have a patient who's suffering from both stress and urgent incontinence, so they have mixed incontinence, and you were to put them on a treatment for overactive bladder, for example, I put them on a medication for the urgent incontinence part, oh, she comes back and says, well, I'm still leaking, the medication didn't work. You got to explore it a little bit. You got to ask them, well, did it really not work, or did perhaps the urgent incontinence get better, but you're still seeing the stress incontinence, in which case we now have to pursue treatment for that as well. So that's why it's important. A lot of times the stress component may persist, and then it's a discussion whether or not that warrants treatment in a different pathway. So again, prevalence of overactive bladder, it's a male and female disease process. It's more common in women. A lot of times some of the male symptoms get confused with BPH as well, but no question that it's more common in women. It definitely increases with age. It doesn't mean you have to have it if you get older. You can live with it if you want, but there's certainly enough treatments that we can make our older patients happier and have a better quality of life. As the patients, the patients who have overactive bladder, usually they manifest with the symptoms. Most of them are dry, or at least about 2/3 of them are dry, meaning they have frequency, they have urgency, nocturia, but they don't necessarily have incontinence. They may be able to get to the bathroom in time. About 1/3 of them are incontinent, maybe a little bit more than 1/3. And most of the time, the people who are incontinent are women. So that may have a factor. Again, the male outlets are longer and they have a prostate, so it can cause a little bit of obstruction, which prevents the leakage. But women have a shorter urethra, they don't have a prostate, so they're a little more prone to the overactive bladder urge incontinence that you may see. So overactive bladder is a fairly prominent condition. I mean, you can see here all the other chronic conditions that a lot of people in practice will be dealing with when they see their patients. And interestingly, arthritis, kidney disease, heart disease, diabetes, they got top press. But overactive bladder is up there as number 1, but it doesn't get as much top press, and that's the problem. That's why we have a lot of people living with OAB who are not necessarily seeing as a medical disease like diabetes or heart disease. It's not on the same playing field with them, so they don't necessarily think it should be treated or needs to be treated. And that's a problem, because while the other diseases may be life-threatening, which is probably why they get all the attention, overactive bladder is a quality of life-threatening disease. And I would always argue that, great, you've made someone live longer, but they're still unhappy, or they're living in the home all day long because they're afraid to go outside. We can do better. I'm not saying we should be competing with the other diseases. We should just do better and treat overactive bladder as well. So a lot of patients, reasons for this lack of care or delay in care, a lot of patients will wait. They'll live with their symptoms. They may think this was common. As you get older, it's something that they expected to see because their parents had it, or they're afraid, they're embarrassed, they don't want to bring it to your attention, or they're afraid the only thing that you have is surgery and they don't want surgery, which is not true, that we have plenty of things other than surgery. So there's often either a barrier for them to come across to seek treatment, or the other problem is that we as providers don't always stir the pot and ask them the questions. They may be more motivated to bring it to us if the bother gets to them, it gets worse. A lot of times they can deal with the daytime symptoms. In my practice, I'll often see when the nocturia gets worse, when they wake up at night more often, or increasingly number of times, that drives them in. And that makes sense because it affects their quality of sleep. Their REM sleep goes down and such, and then has daytime effects later on. Interestingly, men more likely to initiate a treatment about their urinary symptoms, probably because it's socially more acceptable to talk about a prostate problem than it is to talk about a female overactive bladder problem. And again, that's a barrier we should be able to overcome. So how do they present? Well, the I have OAB means they come in and they don't say I have OAB, they say I have frequency, or I have incontinence and I can't make it to the bathroom in time. They won't even say that. They'll say I have incontinence, and then we as providers need to kind of dig into it a little bit. Well, do you have leakage where you can't get to the bathroom in time, or do you have leakage when you cough and sneeze? And lo and behold, based on the answers, you can figure out what they have. You can ask about frequency, and if you have a practice like mine, if you ask how often they go to the bathroom, they'll say all day long. That doesn't really help too much. I like to use activities of daily living, bring them into the conversation. Can you sit through a 1-hour TV show? Can you go to the movies and sit through the entire movie without going to the bathroom? It at least gives you an idea. Movies are 90 minutes to an hour to 2 hours, so if they can make it that long, then they're probably 2 hours. They say, no, I have to cut back on my fluids, and I'll make a mad dash to the bathroom before the movie starts, and at the end of the movie, then you're pushing it. And if they go in the middle, you know for sure that they're going less than 2 hours. And a lot of times they'll say, I can only go to the movies if I don't drink. And again, that's not right. We should be able to control their bladder so that they can do the normal things. Other ways would be if the provider were to try and pull the symptoms out of them. And again, I know in this day and age, we probably have 15 minutes or less to spend time with our patients, and there are a lot of other medical diseases or disease processes that take a priority. But just a simple question, maybe even on the review of systems when they come in and they're filling it out in your waiting room, do you have a problem with your bladder control? At least can open up the discussion. If they say no, fine, you've done your due diligence, keep moving. But on the other hand, if they say yes, I mean, that's a lot for the patient to say, I have a problem with my bladder control. And if they're willing to bring it to your attention, then I think we as providers should really it's justified that we should be asking them more. How often do you go? Do you leak? What makes you leak? Are you waking up at night? Those are the classic symptoms, classic questions to ask. But the other problem again is that the patients, they kind of thinking that they may have it, but if it's important, you'll ask them. You as providers are probably thinking, well, if it bothers them enough, they'll probably bring it to my attention, but they won't do that. We have to ask them because they're just, again, they're either afraid, they're embarrassed, or they think it's normal, and that's a problem with our education, where people's general understanding of a bladder problem, because they may believe it's normal and it's not really normal. So when we're seeing our patients and we want to work them up for overactive bladder, we want to rule other things out. We don't want to treat them for OAB when they really have a urinary tract infection. That's easy to do. That's urinalysis. And we'll go over the workup in a second. Stress incontinence, also not too hard to distinguish between stress and urge incontinence. I leak when I cough and sneeze, when I exercise, when I'm out with my kids or such. That's stress incontinence, as opposed to the I leak when I can't get to the bathroom in time, or when they will sometimes say when I get up, which could mean it's a stress incontinence picture. But ask them one more question. When you get up, where are you going? Well, I'm going to the bathroom. Well, that's probably urge incontinence, or it could be urge incontinence. The waking up at night also is urge incontinence. Leaking at night is usually urge incontinence. Most people don't leak at night due to stress incontinence, and they say are a really, really severe problem. Pelvic organ prolapse. So there the concern is, could you be missing prolapse, and should you be treating prolapse before you treat the overactive bladder? It's a debatable topic. A lot of literature would say the treatment of prolapse doesn't necessarily improve your OAB symptoms. So if you have someone with a grade 1 or grade 2 prolapse, I don't think their prolapse needs to be treated. They should be having their OAB treated. On the other hand, if someone's got OAB symptoms and have, grade 4 prolapse, well, they can have other symptoms from the prolapse as well, and there you can make the decision to treat the prolapse or send to a specialist if you don't do that. Neurogenic bladder is, that one's kind of a gestalt term. If you have a patient with a spinal cord injury, Parkinson's, MS, I would argue that a lot of people can still be treated, but if you're uncomfortable, then sure, send to a specialist. But there are some neurologic diseases where you basically just get an overactive bladder to a more severe degree, and I think you guys can treat that as well. So if you have a patient with a stroke, that's typically going to cause just a more severe overactive bladder picture. I would treat them. I might be a little bit more aggressive with them, or I might make sure I check them after their first treatment to make sure that they got better, because they may need something stronger. But a spinal cord injury patient, that one maybe is better if you're not comfortable with that in the hands of the specialist. Post-surgical, that one, if they had a sling, for example, and they're saying they have urge incontinence, a month or two after sling, it could be they had mixed incontinence and the stress component was taken care of with the sling and the urge component is the only part that's left. It could also sometimes be a problem with the sling. So if they say, well, I never had urge incontinence before the surgery, now I do, that can mean the sling is too tight and it actually needs to be released or relaxed. So that would prompt going back to whoever did their surgery. On the other hand, if they say they had a sling 2 or 3 years ago and they've been doing fine until now, that's probably just routine overactive bladder. I would initiate for first or second line of therapy, and if they don't get better, then I would probably evaluate them to make sure the sling wasn't the problem. Interstitial cystitis has a lot of overlap with OAB. They both have frequency, they both have urgency, they both have nocturia. The real difference is the hallmark symptom for interstitial cystitis is bladder pain. The hallmark symptom for overactive bladder is urgency. So if someone's main complaint is pain, they probably have IC. If their main complaint is urgency without the pain, then it's probably overactive bladder. Pelvic and GYN cancers can cause symptoms, especially if they've been treated, if they had radiation and such. Provider, we don't want to, as providers, we don't want to harm our patients. So can you hurt them by treating them initially? I would say most of our first and second line therapies have low risk. So if you have a patient with previous pelvic cancer or radiation to their pelvis, treating them with a first or second line therapy is not unreasonable, and probably what I would do. And if they don't get better, then again I would send them to a specialist. Vaginitis doesn't really have OAB type symptoms. It's more going to be a vaginal burning, vaginal pain, perhaps a discharge. For medical diseases, polyuria, polydipsia, there are causes of overproduction of urine or inappropriate production of urine during certain time frames. You can have primary nocturia. It can be due to a patient making more urine at night. Perhaps they have a cardiovascular problem. They may have peripheral edema when they're ambulating all day long, and then with all the fluids in their legs, and when they go to sleep, their swelling goes down, all the edema goes back into their vascular system. Now their vascular system has excess fluid, has to get rid of it. They diurese it out while they're sleeping, so that makes them go to the bathroom more often. Diabetes, it's a bad day when me, the urologist, gets to diagnose diabetes, and unfortunately I get to do it a couple times a year. Usually they come in either unknowing that they had diabetes, or they thought they knew they had diabetes, but they were misleading themselves that they actually were well controlled. How do your sugars run? Well, they usually run 120, 150. Well, yeah, really, because your urinalysis today is showing +3 sugar. When was the last time you checked your sugar? When was the last time a hemoglobin A1C was checked? Oh, well, I checked my sugar about a month ago. Unfortunately, not everyone is as tuned to their diabetes control as it should be. So if they have poorly controlled diabetes, you're seeing glucosuria, that's worth delving into, that they don't need OAB treatment yet. They actually need their diabetes under better control. Congestive heart failure, I alluded to, again, can be a secondary cause of nocturia. Medications, such as like if they take a diuretic right before they go to bed, that may make them go to the bathroom more frequently, especially at night. I don't like telling patients how to take other medications for other disease processes, but I would ask them to talk to their provider who ordered it to them, and if they have to take it in the evening versus can they take it during the day. Perhaps it's better for them to take it during the day so they can get some sleep. Alternatively, if they're on a diuretic for hypertension and there are other hypertensive agents that are available that are not diuretics, maybe that warrants a discussion to seek other treatment options. So the workup for overactive bladder is not very complicated at all. We pretty much have done the history. Do you have a problem with bladder control? Do you go very often? How often? Do you wake up at night? How many times? Do you leak? And if you leak, do you leak when you cough and sneeze, or do you leak when you can't get to the bathroom in time? There are validated questionnaires that can be used to help differentiate, as well as to diagnose overactive bladder. Some of them, there are a lot of them that are out there. You can use some that actually will score, in which case you can even give the patient the questionnaire later on and get a determination whether your treatment has improved them by seeing a reduction in their questionnaire symptoms. Physical exams, fairly limited. Again, general exam you all probably doing anyway. Pelvic exam, if you've done them for the once a year, I don't necessarily think it warrants an additional treatment. If you think that you might be missing something, again, the biggest worry is, could you be missing prolapse? And I would argue that if you have stage 1 or 2 prolapse, the exam won't change anything. If they have significant prolapse, grade 3, grade 4, there I'd entertain whether or not the prolapse is contributing versus causing other symptoms. You want to know how much the symptoms bother them. I have plenty of patients who will have nocturia ×3 and leak, and where it depends and such, but I offer them treatment and they don't want it. It's not, like I said, it's a quality of life disease, and it's a shame that our patients have to deal with it. But at the same time, it is not a life-threatening disease, and if they are more fearful of the treatment than they are of the disease process, then it is their prerogative to live with it, in which case we can still help them deal with their symptoms. But I would make a plea that Make sure your patients are educated, or it's our job to educate them that our treatments are not necessarily so bad that we can make them better. The only real test you really should get is a urinalysis, and there you want to rule out a urinary tract infection because that can be treated and then they can get better anyway. And you also want to make sure they don't have hematuria or blood in the urine. Hematuria on a urinalysis by dipstick or gross, obviously gross hematuria, the patient would tell you. But if you have hematuria on the urinalysis and it persists on the microscopic analysis, and the patient has urinary frequency, urgency type symptoms, the concern there is could it be a bladder cancer or a bladder tumor? That does warrant an evaluation. You do a formal urinalysis with a micro to make sure it is true hematuria, not just a dipstick, and then you send them to your friendly neighborhood specialist for an evaluation. It's usually an imaging study of the kidneys and then a cystoscopy, which these days are certainly less invasive than when I trained. It's about as invasive as putting in a catheter these days. A cystoscope is about the same size as a flexible catheter, flexible cystoscope. It's about the same size as a regular 16 French catheter. It takes about 2 minutes to do under local in the office, and your patient can be cleared of any bladder tumors and such. Bladder diaries are always nice when you can get them. Problem is patients don't always do them, but it helps put their symptoms into a reality check, because a lot of times you'll say, oh, how often are you going? And they say, I'm going all day long. Well, they very well may be going more often, and they'll say, I'm going every 15 minutes. Well, the diary will really confirm if that's true or not. Additional testing, so if the urinalysis is positive, there's enough evidence that you can probably just empirically treat UTIs. But if you have a patient based on a UA, but if you have patients with recurrent UTIs or a more complicated situation, then a urine culture is appropriate. Post-void residuals, which is the assessment of how much urine is left in the bladder immediately after the patient voids, it's not a requirement for overactive bladder symptoms or for the treatment of overactive bladder. It might be a good idea for the more complicated patients, that patient with poorly controlled diabetes. We worry about them having a diabetic cystopathy or diabetic neurogenic bladder, where their bladder isn't empty. They're basically overflowing, and you find that they have a very elevated post-void residual. In the olden days, we used to catheterize people for post-void residual or PVR. Nowadays, there's bladder scanners, which is fairly easy and non-invasive to do. I just came back from a meeting talking about what is the appropriate post-void residual, and certainly the numbers that are listed here, less than 50, indicates efficient voiding greater than 200 is concerning for retention. I wouldn't argue with those numbers, but there's a lot of distance in between the two. So if a patient came in with 75 cc's residual, I personally wouldn't be too worried about it. 100 cc residual, I probably wouldn't be too worried about it. Often it's also important to know how much they voided. So everyone says, oh, 25 residuals, not a problem. Okay, well, I'd agree with that no matter what. But if they had a 50 cc residual or a 75 cc residual, but they voided 400, that's not going to be a problem either. If you got someone who's got a residual of 200, for example, that could be a problem. But I've got a lot of patients who will void 500, in which case they leave 200 behind. That's not so bad. If you actually do the math, cut it down. If they voided 250 and left a residual of 100, all of a sudden it's a little bit more palatable. So it's not always just the number. But you do want to make sure that they're emptying reasonably well, and if they're not emptying well, then are they getting UTIs and such, and that's where I would entertain whether or not that number is too high or not. If a patient had a previous sling, recently especially, if this number is elevated, I would be concerned. If they're on antimuscarinic therapy already, that might be a reason. That might be an indication that they're on too much medication or need a different therapy. You also, if you have a patient with a high residual, that may not be the best patient for an antimuscarinic. We talked to them about other therapies. So it's an important number, but it's not something you have to do for all patients. It's really just going to be for the special patients, the ones who maybe didn't respond, or the ones who come in with other complicating factors. So I think I alluded to this slide earlier. What questions should you be asking? Do you have strong sudden urges to urinate? Do you have to go to the bathroom so often that it interferes with your quality of life and your activities? Do you wake up at night? How frequently do you wake up to go to the bathroom at night? And are you bothered? And then do you leak on the way to the bathroom? Again, we alluded to this earlier. General exam you all are probably doing anyway. Vaginal exam, again, you're going to be looking for things like prolapse and significant prolapse. Atrophic vaginitis is important to assess for because a lot of times the symptoms for atrophic vaginitis will sometimes cross over, and also we'll find that treating their atrophic vaginitis will often improve their OAB symptoms. In addition to that, treating their atrophic vaginitis in conjunction with their OAB symptoms may give you a lot bigger result and significant more improvement than if you just treated one versus the other. Neurologic exam, you really just, it's a general neurologic exam just to make sure that we're not missing any, neurologic diseases. Every once in a while, the bladder could be the first presenting symptom of something like MS. Patient may have urinary frequency, urgency, leakage, and such, and in which case they didn't have the other neurologic symptoms of MS yet, but it could have been. I don't know if we'll pick it up on our neurologic exams or not, but we always talk about it. Urethral diverticulum and masses, essentially, again, kind of rare. Masses you've been picking up as part of your general vaginal exam anyway. Urethral diverticulum, a lot of times the patient will have pain with intercourse, pain when you're doing your exam. Basically, it's usually a small sac along the, right in front of the urethra or along the urethra, tender to palpation. If you push on it hard, it'll hurt. You also will get a little bit of pus coming out of the urethra. These patients often will tell you pain with urination, pain with intercourse, frequent UTIs. Again, if they have a normal pelvic exam, I wouldn't be too worried about missing. So the algorithm for this, basically history, physical, urinalysis, those are the required things. Those are the things we all should be doing. And based on that, you can initiate treatment. If you're concerned, you can get additional testing. But most of the time, we can go straight to first-line therapy and actually secondary therapies and such based on how they do. But there's nothing wrong with doing your history, physical, urinalysis, and then going right into the treatment if you're confident they have OAB. The American Urologic Association and the Society for Urodynamics and Female Pelvic Medicine and Genital Urinary Reconstruction, which is a long acronym, long name for an acronym called SUFU. AUA and SUFU came out with OAB guidelines that looked at the workup for overactive bladder as well as the treatment. The workup is there, and then the treatment basically is tiered. First line or tier 1 involves patient education, teaching patients about what's normal for their bladder function, what's normal bladder habits. Some patients, I've had patients come in waking up 3 times a night. I treat them and they come back saying, well, now I'm only waking up once, but I still don't like it. Well, guess what? That may be where you have to be because normal people in your age do wake up once a night. So getting their symptoms into a reality check and understanding what's normal and what's not normal, what is reasonable for expectations and what's not, is important in that first line therapy. It realigns them, gets them into reality. Teaching them about fluid management, avoiding caffeinated beverages and bladder irritants and such. That often helps. Patients who have nocturia, who will drink a glass of water right before they go to bed because they're taking a pill, or maybe they had dinner at 6 o'clock and they go to bed at 10 and they have 2 or 3 glasses of something in between. It sounds simple to us, and I'm not making fun of our patients at all. I've learned this from my own patients, is that they don't make the connection, and it's our job to help them make that connection. So if the patient doesn't realize it, a lot of times we can just simply help them. Look, you don't need a full glass of water to take your pill before you go to bed. You just need enough to swallow it. And a lot of times that'll take down one void right there at night. I'll do a little experiment with them. I'll tell them to calculate what they drink between dinner and going to bed and cut it in half for a few days. Just see if that makes a significant difference or not. And a lot of times it will, and then that just kind of snowballs into them proceeding and pursuing more and more of behavioral therapy and dietary modifications. Tier 2 is pharmacologic management. Ideally, we love it if all our patients did tier 1 and did well with it. They wouldn't have to go to tier 2. but many patients don't do well, or some patients don't want to do the first-line therapies, and that is their prerogative. They do not have to do it in order to jump to tier 2. We just have to offer it to them. Some patients just want a quick fix and they want a medication so they can get on with their busy lives and such, and that's something to consider. I'm not trying to belittle tier 1 at all. I actually strongly advocate for it, but I would hate to see a patient not get a medication because they weren't treated by tier 1 because they didn't want to do it. So there's different medications that we'll talk about shortly. And then again, after each tier, you reassess them and see if they've met their treatment goals or not. And if they haven't, then you can talk about whether or not they should go to a tier 3. If you do tier 3, great. If you don't, then appropriate time for referring to a specialist. So we as providers can really, education is the key to a lot of this, and we as providers can help here. Primary care people talking to their patients, improving bladder health literacy so that they understand what is normal and what's not normal. Patient education in terms of their expectations, which I alluded to earlier. Also, if they see it, they may be more adherent to their therapy. That's why I do that little experiment where I tell them to cut back their fluids for half the fluids in the evening, just for a few days, because if they see the improvement, a lot of times that it's a positive feedback, and they'll want to do it even more. All patients should be offered behavioral therapy and behavioral treatments. And there's a lot of partners in this: nurses, healthcare educators, mid-levels, their caregivers at home. If they're in a facility, the nurses that work with them or the caregivers that work with them, prompted voiding, helping patients go to the bathroom, especially if they're in a facility. There's a lot to this. It's not just a simple pill. In fact, I would argue that in these cases, a simple pill will not work. They need all the other components plugged in as well. SUFU, the AUA SUFU guidelines are important for this. SUFU also has materials. I'm sure every specialty that deals with this has their own education materials. It would be nice if people had what we call the nurse navigators or the provider navigators, which can kind of steer patients along and make sure they go from step to step. Because a lot of times they'll go to step 1, they don't do well, and they just decide to just put it off and not deal with it anymore, whereas the navigator will help push them through the next step where they might see the benefit. SUFU has a clinical care pathway that they use. You can get that on their website, which acts as a navigator if you don't have one yourself. It actually puts it back in the patient's hands to they get a little roadmap, and they tell little time points to see you're 4 weeks out from your medication. Are you better or you're not better? It also has educational materials that they've talked about there, so it's a one-stop shopping place. I'm sure that the other entities, OGS, will have it. ARHP might have it. Okay. So pharmacologic treatments for overactive bladder. So we've offered our patients first-line therapy. They come back and they say, well, I've cut back on my fluids. I don't drink as much coffee or soda anymore. I'm better, but I'm not where I want to be. And we talked about my education goals, and I really want to get better. So we can offer them second-line therapies, which are pharmacologic agents. And they're basically broken down into the antimuscarinics, the beta-3 agonists, and botulinum toxin, which is an injection. The other two are so beta-3 is an oral agent, and the antimuscarinics are oral with a few topical as well. But Botox is a little more invasive, but it is still a pharmacologic agent. Okay. So the rationale for the anticholinergics, the bladder contraction is manifested by the cholinergic pathway. The parasympathetic nerve that goes to the bladder is in the pelvic plexus. The nerves in the pelvic plexus are parasympathetic and sympathetic. It's the parasympathetic that actually makes or causes the bladder contraction, and it does that by using a neurotransmitter called acetylcholine. Acetylcholine can bind through any of the muscarinic receptors, and there's 5 different muscarinic receptors throughout the body. The bladder is mainly populated by M2 and M3 receptors. So then M3 is the one that's thought to be responsible for the detrusor contraction, but it's kind of believed that the M2 is probably also involved in sensory. And if you want to help the bladder symptoms, the frequency, urgency symptoms, a lot of times you want to hit M2 and M3. So There's advantages to using a more specific or targeted antimuscarinic. On the other hand, you want to hit M1, M2, and M3 if you can. So you can see this is a cartoon looking at the different receptors. So we mentioned earlier, in the detrusor muscle, most are so M3 is responsible for the bladder contraction. M2 is the more popular one, and again, it's probably involved in sensory or other stuff that we're just not aware of yet. If I want to block bladder contractions, I would want to block this receptor. I would use a blocker of acetylcholine or an anticholinergic. The other pathways that are involved here are the sympathetic system. So if the parasympathetic system mediates a bladder contraction, the sympathetic system does the opposite, which is usually facilitates storage or improves storage. So that's coming through the hypogastric nerve to the bladder, and there the neurotransmitter is noradrenaline. So if we wanted to improve OAB, we would want to enhance the sympathetic pathway. That would be using a sympathetic agonist, or in this case, a beta-3 agonist. So a beta-3 agonist facilitates storage or improves storage, while an anticholinergic improves storage. So looking at the anticholinergic first, you can see this is a list, and there's another page if I recall. Nope, got them all here. So there's all the anticholinergics are listed. Some are, and their trade names are there as well. Some are muscarinic receptor specific versus others that are more non-specific. So darafenacin, it really got its claim to fame because it has a higher affinity for the M3 receptor. Benefit there is if it targets M3 more than the others, you might get less of the systemic side effects. Unfortunately, there's still plenty of binding to the other receptors as well. You still get the side effects. Fesoterodine also it's a less specific. I think it goes to M. Don't quote me on which ones they go to. Oxybutynin I know is a non-specific one. You can see also the different routes. So darafenacin has it's an oral route, and I'm only aware of the extended release version, at least in this country. The fesoterodine also extended release oral version. Oxybutynin has a extended release. It has an immediate release one as well. It also has a topical agent via patch or gel. Solifenacin is extended release oral only. Tolterodine comes as a tolterodine immediate release or extended release, also only oral. And then trospium, missing there the brand name Sanctura, but it also is oral, and it's got a immediate versus extended release options available for that as well. So are there any differences? Well, if you look at the studies that are out there, there's probably a study for each drug that says they are better in one way or another, but you have to look at those with caution because a lot of times they're funded by the companies that make the drug. And I'm not saying that they're wrong, but most people will tell you that in one metric the efficacy may be better in one drug versus the other, but then in another metric it may be the other way around. So it's really, really hard to say. They are most of us don't really consider a difference. And a lot of times it may be a dose-dependent thing. So maybe a patient on one medication with a lower dose will have less side effects. It may not work as good. But again, their claim to fame is they have less side effects. But if they up the dose and got something more effective, then it would work better, but then the side effects come in too. So something you have to weigh in. And it really is a balance between the efficacy and the tolerability. Unfortunately, these days, what often dictates which medication we use is the patient's prescription plan and formulary that they belong to. So these are just ranges of the degree of improvement that you may see when you put someone on an antimuscarinic. Urgency reductions anywhere from 40 to 63%, urgent continence 57 to 77%, reduction in frequency 17 to 28%. And everyone looks at that, oh my gosh, the frequency is not that improved. Why is that? Well, don't forget, your patients, the idea for urgent continence, I want to get them 100% dry. I want to get zero incontinence. I would love to get zero urgency. I can't get anybody to zero frequency. They've got to pee. So there, the goal is usually to get them to at least 8 voids a day or less, because that's what's considered normal. But it makes it a hard number to see improvement on, because they are still going to be peeing to some degree or another. Concerns with antimuscarinics, again, the side effects, the ones that often are a problem are the dry mouth and constipation, but the ones that are more concerning in terms of what could be affecting their other medical problems, or could cause other medical problems, the risk of antimuscarinic causing CNS effects, memory dysfunction, memory impairment, cognitive dysfunction, especially in the older patient population. Think about it, patients with dementia, they get cholinesterase medications to improve their, this is the opposite. So a lot of times there's a question, should you even be giving someone an antimuscarinic if they have dementia or memory problems? Enough so that some of the antimuscarinics are on the Beers criteria. They're not appropriate for the older population. You can make the argument other ways too. I had one lady who came in with her daughter, and we put her on an anticholinergic. I'm not going to mention names. I'm not trying to badmouth anybody. And they saw the improvement. And then about a year or so later, they came back and saw an article in the lay press about the medications causing memory issues, and she has already memory issues. How dare I put her on a medication that could have made her worse? So we stopped it. And then they called up about a month or two later, wanted to go back on it again because the patient was having worsening nocturia. The somnolence got real bad, and that was causing more problems than anything else. So it is weighed in, but I agree. In general, we want to avoid antimuscarinics in older populations, especially when they're at risk for these diseases. There's a theoretical concern about effects on heart rate and QT interval with the antimuscarinics. I can't say I've seen it, but it's a theoretical concern. Cognitive side effects. So there is one. The trospium is a quaternary amine that is supposed to have such a large molecule size that it can't cross the blood-brain barrier. If it can't cross the blood-brain barrier, it shouldn't really affect memory and cognition. On the other hand, a lot of our older patients will have other disease processes that can make that blood-brain barrier a little bit more permeable, and then in which case they're at risk for these problems, even with a molecule like trospium. The other side effects that often bring them in or make warrant phone calls, dry mouth, constipation, dry eyes, and such. Sometimes a little bit of reflux and such. If you start seeing significant reflux problems, or you have a patient with gastric emptying problems, that may warrant not putting them on and having them see a specialist. If you have a patient with narrow-angle glaucoma, that's a contraindication. These days, narrow-angle glaucoma is fairly rare anyway. It usually gets treated surgically very quickly, so it would have gotten treated by the time you see them. They should not come in with, hopefully they're not coming in with a diagnosis of narrow-angle glaucoma that's not already been treated. Open-angle glaucoma, that's a different story. And then retention, again, if you've had a patient with retention issues or elevated residuals, maybe they don't belong on an anticholinergic, or at least maybe they're better in the hands of a specialist because they'll be monitoring a little closer. This last bullet on the bottom is probably all the whole telltale. Vast majority of patients discontinue anticholinergics by 1 year. And that's, again, the effectiveness versus tolerability balance. And a lot of times tolerability gets worse or just becomes more of a problem for them, and they end up stopping the medication. That's on antimuscarinics. This is just a slide. I'm going to move a little bit because I want to make sure we get to the case and we have time for questions. This is a slide looking at the different antimuscarinic different muscarinic receptors relative to the different types of side effects you can have, and you can understand why maybe such as the darafenacin molecule, I thought it was M3, may have a little less of some of the others because it's only restricted to M4 or M3 versus, say, an oxybutynin, which can go to all of them, and then because it's non-selective, you may get a more vast degree of side effects. This is just the same thing, and I guess clotaridim was once reported, but I would say dose greater than 8 grams per day, we're not going to hopefully get that high. Okay, so then the next oral agent is beta-3 agonist, or mirabegron. Currently the only FDA-approved beta-3 agonist. Remember earlier we said you want to block contractions by blocking the cholinergic, so that's the anticholinergics. Or you want to facilitate the sympathetics, so this is the agonist for the sympathetics, the beta-3 agonist. Been approved since 2012. It's thought to be safe and effective alternative to antimuscarinics, with fewer of those side effects that we were talking about. Again, it works via the sympathetic pathway, stimulating beta-3, causes relaxation or at least facilitation of the storage cycle, and hopefully not affect the voiding cycle, at least not as much as, say, the antimuscarinics. If you think about the antimuscarinics, are going to block bladder contractions that are pathologic. They're also going to, they can't distinguish between a normal bladder contraction versus an unstable bladder contraction. The beta-3 is supposed to facilitate storage, and it's hopefully not going to block the bladder contraction. At least that's the theory. So it does not interfere with the voiding process, and hopefully have less risk for causing urinary retention. Efficacy is thought to be similar to antimuscarinics. There's a 25 and a 50 milligram dose that are FDA approved in this country. There was a 100 milligram dose studied in Europe. I don't know if the 100 milligram dose actually ever got approved there or not. But in this country, it's 25 and 50, and they always make those decisions based on looking at the efficacy versus tolerability versus the risk of a tolerability issue. I'm guessing that the 100 milligram dose compared to the 50 wasn't that much different, hence they only went with the 25 to 50. And you can see this is one of the medications where if you up the dose, the side effects don't usually get worse. So the antimuscarinics, you could have someone on a lower dose. It worked. It was tolerable, but it didn't work as good as they would have liked. You up the dose, and then the dry mouth and the constipation become debilitating, and they have to stop the drug. Whereas with mirabegron, if you start them at 25 and they see improvement, you bump them up to 50. At least in my experience, they don't call back saying, "Well, I can't stay on that high dose because it's too high. I'm getting too many side effects." So that's a good thing on its behalf. There was one study in Europe that did look at all three. I cannot tell you that they actually compared them. I think the adverse events they saw was similar, but no one can talk about the efficacy rating because the study wasn't powered to compare them actually. But yeah, in terms of adverse events, as you can see there, the reporting it was similar. Hypertension is one of the concerns, but again, in this long-term this European study, I think the effects were similar. QT interval prolongation in 200 milligrams, so don't give your patients that high of a dose because it's only approved for 50 milligrams anyway. And then dry mouth, much more common in tolterodine versus mirabegron, again, because of one's an anticholinergic and the other one is not. Side effects, hypertension is the concern, the FDA warning about it. If you have patients who poorly controlled hypertension, they probably would not be best on this medication. You have normotensive patients or hypertensive patients who are well controlled or even reasonably controlled, then it would be okay. And then as a person though, these patients usually check their blood pressures anyway. I just tell them to keep a close eye on it. It's been rare. I don't see too many people having to stop hypertension, but I do warn them about it. So you can see we need, the studies that are available so far. This is a relatively new drug, so we have studies that are going out 12 weeks. We do need longer-term studies, patients with morbidities, the older patients. The mirabegron medication is broken down by the CYP2D6 pathway. There is a theoretical concern with CYP2D6 other medications that use that pathway, such as metoprolol or remind myself, dicipramine, which is not too used that often, but metoprolol is. And if you have a patient, metoprolol is broken down by CYP2D6. If mirabegron slows down the CYP2D6 pathway, you could in effect be giving them a little extra metoprolol, which is not always a bad thing, but it's not something that I want to do, at least as a urologist. So if you have a patient with a low blood pressure or a low heart rate, and you put them on, and they're already on metoprolol, I would be a little worried with mirabegron because you're effectively giving them making their metoprolol last a little longer, so you could make them a little bit slower heart rate or drop their blood pressure a little bit lower. But for the most part, patients with normal blood pressures and normal heart rates, it really shouldn't be too much of a concern. So currently, most patients get put on an antimuscarinic mainly because of the formulary issues. And then they get put on a beta-3, the mirabegron medication, if the antimuscarinic doesn't work. There actually isn't a hierarchy that says it should be one versus the other. There's no good evidence that says one drug is better than another. It's just that is typically the way it's done because of the formulary plans. I mean, there are generic options for the antimuscarinics. They are not for the beta-3. So not uncommonly, a patient will first be on 1 or 2 anticholinergics, probably the generics, and if they don't get better, then a lot of times we'll switch them to the mirror background medication. On the other hand, if they have a plan that's fully covered, that covers everything, then there's no hierarchy that says one has to be used before another. And you can put a patient on mirror background first. You can put them on an anticholinergic first. It's your call. And then you can see there is some consideration for using them in conjunction with each other. These would be the really refractory patients who didn't respond to one or couldn't tolerate a higher dose of one. It does make sense because they work differently. It's one thing to say I'm going to use 2 antimuscarinics. That to me theoretically doesn't make as much sense because you're just using 2 antimuscarinics that are going to, from a pharmacologic standpoint, do the same thing. They're both going to slow down the parasympathetic pathway. Whereas if you're going to use an anticholinergic or antimuscarinic, it's the same thing. And you use a beta-3 agonist, they're hitting the bladder in 2 different sides, so they may actually be beneficial in that way. And there is work being done to look to see if that's appropriate. There are people who do it. There's studies that are being done to see if it's backed in evidence. I mentioned earlier about atrophic vaginitis. If you have patients with vaginal dryness and irritations and such, a lot of times treatment of the atrophic vaginitis will improve their OAB symptoms. If nothing else, it also may enhance their response to your OAB therapy. So just bear that in mind. There is concern that oral estrogens, this came out of the Women's Health Initiative, the WHI, oral estrogens actually was thought to worsen the risk of stress incontinence. I'm not talking about using oral therapies. I'm talking about using a topical estrogen cream or such for atrophic vaginitis. That should not impact stress incontinence, and it doesn't carry nearly the risks as the other ones. So as we're getting hopefully to the end, so when to refer to a specialist, again, hematuria, your diagnosis is unclear. If they have obstruction, you have significant prolapse. I would argue if they have grade 1 or grade 2 prolapse, they should be staying in your hands. If they don't respond to the medications, if you have an elevated residual or you're fearful of that, recent pelvic surgery, bladder pain, because now we're talking IC, neurologic diseases, and again, I think everyone who treats OAB can treat a stroke patient with OAB symptoms, but if you've got a patient with a spinal cord injury, that probably does warrant a specialist. Botox, so they've failed their first and second line therapy, they go to a specialist. We can offer them basically neuromodulation, which comes in 2 different flavors, as well as botulinum toxin injection. Botox injections, fairly successful. It's Botox type A. There are different brands of Botox. You can see Dysport, Botox, and I don't even know how to pronounce that one, Xeomin. I can tell you the only form of botulinum toxin that is approved for overactive bladder in the United States is Allergan's Botox. So you see them here, and I'm just bringing that up. I'm not trying to cite prove one company or the other, but realize that the only ones that are FDA approved would be Botox. The other would be off-label. Neuromodulation, again, comes with sacral neuromodulation, where you implant a device. It is a surgery. It's a minor surgery, but it is a surgery, outpatient type surgery. I do mine under local with sedation most of the time. The device is a neurostimulator device, not that different than a pain stimulator. Probably about the size of a 9-volt battery, but half as thick. And you have a sacral electrode that's placed percutaneously. Everything's internalized, and it's been shown to be very effective with a duration of anywhere from approximately 5 or 6 years. They do a trial version to see if it works before they go to surgery, so that kind of stacks a little bit in their favor because the patients who respond move on to surgery, and they should do well. The patients who didn't respond don't move on to surgery, and so you keep your numbers a little bit better. PTNS, or peripheral tibial nerve stimulation, is a office-based procedure where we we place a needle that's very similar to an acupuncture needle in the posterior tibial nerve area, usually in the ankle area, and we stimulate using an external stimulator. I think it's 30 minutes, and you go through weekly sessions for 12 weeks in the hope that it's going to cause neuroplastic changes to change the bladder at a higher level and reduce the overactive bladder symptoms. Botox injection, I didn't actually go into the mechanism of it. Botox is injected directly into the bladder with a cystoscope. It's an office-based procedure. It can be done in the operating room as well. I do mine mostly in the office under local. The botulinum toxin is injected into the bladder wall. The Botox then diffuses and gets into the nerve cell and blocks the release of the acetylcholine, and now you've got reduction in the bladder contractions. Unfortunately, I needed that acetylcholine to cause the normal bladder contraction, so they are at risk for retention, but I think it's about a 6% risk. It's not too high. And then for the really, really rare patients that don't do well, we talk about either a bladder augmentation, which is an enterocystoplasty, or urinary diversion, which can be a conduit. It can be something as simple as a catheter or a suprapubic tube. I have had one patient who came in with such bad OAB that they actually caused a severe perineal rash, and I put a catheter in just for about a week or two to make her rash go away, and lo and behold, it did, and I looked like I was a hero. We took the catheter out and tried her on several OAB therapies. It didn't respond, and she said, "Doc, can I have that catheter back?" It wasn't the best option, but in her case, individually, it might have been. So,
Dr. Krause, I unfortunately need to cut you off right here so we can wrap up the webinar, but thank you so much. And for everyone on the webinar and viewing this webinar on demand, please do head to core.arhp.org to see more on Medicaid and Medicare reimbursements, as well as the case presentation that you can see here. At this point, we can begin taking questions that have been entered into the chat box.
Okay, do you have the chat box? I cannot see it. Or I do see it, but I only see, I guess, the welcome message.
Yep, I have it right here. So our first and only question is, what are your top 3 key points about OAB for sexual and reproductive healthcare providers who are new to this topic?
My top 3, what was that one word I couldn't hear?
Your top 3 key points about OAB.
Key points. So I'm going to assume that the first point would have been, like I mentioned earlier, getting in there and talking to your patients, making them aware that it's a disease that they don't have to deal with, they don't have to suffer with it, that you can help them with it. Number 2, the workup is simple, the history. We went over that, and the only thing you need to do is a urinalysis. You don't need to do cystoscopies. You don't need to do any special tests, urodynamics and such. That is really not indicated for the regular OAB patient. I do advocate first-line therapy, and there are lots of, I mentioned the SUFU clinical care pathway, but there are lots of other entities as well. I'm just familiar with that one the most, but they really will help your patients when they can go home and learn about their bladder, what it's supposed to do and what it's not supposed to do. That's medical or healthcare literacy, I think, is a worse problem that we give credit for, and they just don't realize what's expected, what's not expected, what's normal, and what's not. So I would say that.
Perfect. Thank you, Dr. Krause, and thanks to Astellas as well for the independent educational grant referenced at the start of this webinar. Before we end today, I just have a few important reminders. We invite you to visit arhp.org and register for our upcoming webinar series on cervical cancer. As I mentioned previously, please also visit core.arhp.org to view this and other slide decks. As a reminder, you will receive an email from the ARHP education team in about an hour containing a link to the post-test survey. Your CME or nursing CE certificate will be generated at the end of that survey. Please be sure to print your certificate before closing your internet browser. If you have questions, just feel free to email us at education@arhp.org. Thank you again for joining us, and thank you again, Dr. Krause. We hope everyone will take part in other live and on-demand sessions hosted by ARHP.
Great, thank you for having me. I hope everybody got something out of it.